Okay, welcome to our experience. I'm Chad Wers, Chief Executive for the American Society of Consultant Pharmacists, alongside in person
Finally.
Tom Hansel, who is our co-host on this podcast. This is season 2, and today we're going to be talking about one of our innovative topics. Innovative, certainly since COVID, but leading, not bleeding, vaccinations. And we've got with us a special guest, Patrick Cote, who's the Director of Pharmacy for the Lutheran Good Samaritan Society. And I'm going to let Patrick kind of explain what he does. Just as an overview, he represents one of a few pharmacists around the country that have a leadership role for a nursing home company. We call them nursing home executive pharmacists. We have a focus group for them, but it's not a very big fraternity. It's a smaller one. But we think it's a place that's growing, and certainly it really represents the complexity around providing pharmacy services, both on the logistical end as well as on the clinical end, and the need for pharmacists in those roles. So Patrick, welcome.
Thank you. Yeah, so as you mentioned, I'm the Director of Pharmacy for Good Samaritan Society. We're the largest nonprofit provider of skilled services, but we're also, I think, we're not unique, but that we are fully integrated with Sanford Health, which is, if you're from South Dakota and North Dakota especially, but also Minnesota and Iowa, you know what Sanford Health is. If you're from other parts of the country, you may not have heard of it, but it's
awesome. Just a real quick question off the top, because of where you're from. It does seem to me that in that part of the country, for whatever reason, we seem to do healthcare better. We hear a lot of good pull through on programs. I know from the vaccination perspective from COVID-19, that area of the country led the rest of the country in terms of being able to deploy vaccines and treatments. I mean, is there a reason for that, or is it what's your take on that?
Yeah, it's hard to, we've been asked about that a lot lately. I work very closely with our lead infection, and she got a one-on-one audience with, someone pretty significant with HHS recently. Even positive nursing home news is very
right.
The story was picked up, but nationally about, hey, look at South Dakota and North Dakota, what the heck is going on here? And some of it is, I think, one piece that could be is we're dealing with pretty rural states, and we're dealing with Sanford Health, with a very large system that has a very loud voice, whether that's a political voice or a business world voice in all of those communities. So I think that's a significant impact. And it's not just Sanford. There are other significant health systems in that area too. And then I think we should give the people of North and South Dakota, for example, some politics of community vaccination versus what it means to live in a communal setting in a nursing home and what those risks are. So I think it's easy if you're on the left coast or the right coast to stereotype about the middle of the country, but I think people are a little bit smarter than folks may give them credit for in terms of being able to delineate healthcare.
Yeah, I think it's great. I think I've always been interested in finding places that are overachieving or succeeding when the challenge is as great as it is. We've spent a lot of time talking about blue zones where people live into their hundreds, and what's the reason for that? Is it their diet, their exercise habits? So when you find pockets of places that do healthcare well, you want to figure out what the magic is and how do you replicate it.
So Patrick, did you guys have vaccine mandates in those areas, and do you still have them today in certain settings?
So for Good Samaritan Society and Sanford Health, somewhat related, we've had a long time influenza vaccination mandate for employees. So there was that culture of essentially 100% vaccination rates of employees that I think was helpful. And I think, again, as a rural health system, Sanford really led the way on that. And as we came to merge with them, we had more of a mandatory reporting for employees and we shifted to their policy of mandatory vaccination. So I think that was somewhat helpful. With COVID, we followed national regulations and policy, so it was mandated kind of early on, but so nothing that's happening with recent vaccination rates has anything to do with mandates. It's completely choice of staff and residents.
I'm gonna reverse things a little bit. How we're gonna talk today. Can you talk about your vaccine program with your skilled nursing facilities? How does it work? Who does what, and how do you deliver it?
Yeah. So taking half a step back to maybe why we were so successful, I think, and I know we're an audience primarily of pharmacists and pharmacy people, and this is one example, and I don't want it to be the only example. There are many others, but a pharmacy chain called Lewis Drug in Sioux Falls has a very robust community vaccination program that they've extended into the long-term care setting as well. And it's full service. It's, from providing the vaccine to administering the vaccine, and they've gone after it. They've gone after it hard, and they're doing a great job with it. And so for our 19 locations that are serviced by them, we kind of didn't have to do anything, right? We had to do a good job communicating with our pharmacy. We had to be willing. I don't want to get into the complexities of billing right now, but we had to be willing to give up a little bit of our revenue for administering. Those we gave it all to the pharmacy in those situations and let them handle it. And so that's a really, for an audience of pharmacists, that's a great way to help nursing homes and really help us get to a very high rate. And, Canton, South Dakota, that got national recognition, is a Lewis Drug Service location. So it was the pharmacy that actually did all of the vaccinations there. So that's one piece. But we knew early on, we've got locations in 20 states, and we have a variety of pharmacy service providers, from true long-term care pharmacies to more of a typical community pharmacy that might take care of one or two nursing homes. And so we really believe the only way to succeed with vaccinations strategy, where we set up a program to get vaccines directly from one of the major manufacturers, and that was through a Sanford Health contract. Our nursing staff in every single one of our locations knows that they can administer these shots, and we assisted from the national level, just trying to create that access piece. Then our infection preventionists really hit hard on kind of the acceptance part of it. So my role is finding vaccines for all of our locations, and the infection preventionist role is to try to encourage people to actually do it.
I mean, I think that's a great example, and I appreciate how you described it, because when you're involved at the policy level or at the advocacy level, and you've been part of some of those meetings, you tend to feel like people are like, well, this is how you have to do it. And, there's people on one side saying, well, pharmacists should do it and they should be able to bill for it. And then the other people on the other side might say something differently. But what we're really after is the ease and the flexibility of doing it, because not everybody's going to fall into the same environment. You are going to have places where maybe the long-term care pharmacy that does provide meds to that facility doesn't want to do it, and the community retail does want to do it, and they come in and do it.
It's really in the best interest of the patient.
Right. It should be easy for anybody that's willing to do it to do it. And I think a lot of our policies at the CMS level and some of the payment policies make it a challenge, because it forces people into a complexity that they're not really motivated or desire to get into. So when you get into the way it is now, if the pharmacy might want to do it, they can only do some of it. They can't do Part A without building some sort of contractual relationship. The facility can't bill for administrations for Part D vaccine. There's all this stuff. And the reality is it just should be easy. Yeah. And it doesn't matter if it's the facility that wants to do it or the pharmacy that wants to do it. It should be easy. That ultimately gets more vaccines in arms. And it's been really hard to get the government to recognize that. They don't really recognize.
Well, everything becomes political, right? So,
well, but it just becomes... They kind of like, well, I don't know why you can't do it. It says right here, the nursing home can do this and the pharmacy can do this. I'm like, yeah, that's a lot to get these two entities
Mhm.
to figure out.
Yeah.
Like, whereas just take down some of these barriers and make it easy for everybody, and they will naturally fill in the gaps.
Yeah.
So,
I mean, that's a real testament to, I think, just that area again. I had a chance, actually, I was in the Dakotas last week, and first time that I traveled to the Dakotas. So we flew into Fargo, and I was expecting 12-foot snow tunnels, and it was like 50 degrees. I thought, this ain't bad.
Mhm.
But drove down through South Dakota on the way to Omaha. And one thing I obviously is very noticeable on I think I-29 is you've got these wind turbines everywhere. And, I was sitting there trying to count them all, which is a little hard at 80 miles an hour. But I thought, man, how much of the state is powered by these wind turbines? Because I've never seen so many of them, and it just makes a lot of sense. And I don't know if Google led me right, but it's something like 85% of the state was powered by these. And I thought, man, you never hear anything about this. Other parts of the country are fighting for or fighting against this. But here's South Dakota, which for the most part is a Republican state. They got reusable energy all over the place. You never hear anything about it, and they're doing it probably better than anyone else.
Yeah.
Just a real testament to kind of the forward thinking.
yeah. Well, Patrick, give us a little history of, how did you get here? Where's your pharmacy career taking you?
Yeah. So pharmacy is a second career for me. So I started, I was a ski racer in college and pursued that a little bit beyond, and then worked for a regional ski organization in New England that was really kind of taking kids from the cradle up through Olympic teams in the East, and then I wanted some new challenges. Originally thought I'd go to med school when I was an undergrad, and really started reading about pharmacy and got excited about it. And through right away when I started pharmacy school, I was at Creighton University in their distance program, and I was able to get an internship with Maine Veterans Homes right away. And you may be familiar with Maine Vets, small nursing home chain for veterans in the state of Maine that operates its own pharmacy. So right away I started interning with them, and then I ended up taking my first job with them and working up through, and clearly from the beginning became really interested in the clinical realm of pharmacy, and created a program there where we did bedside counseling of residents who are coming in or discharging from our nursing homes, always with the pharmacist directly, and did a lot of, I think, really the type of stuff that I think is really clear in theory for transitions of care, but it's really hard to implement. We were in a good situation where we could afford to implement those interventions. I had good success with it, and then ended up being recruited and deciding to take the position with Good Sam as their first director of pharmacy, and that was eight years ago now. And then the thing is, when I took the job, I thought it was to be a clinical pharmacist, and right away I walked through the door and was told, you need to find $2 million of pharmacy savings, but don't make our locations change anything that they're doing. And so it was an interesting challenge, and through a variety of things, we actually figured it out, and I learned that I like the business side too. So 8 years in, I feel as comfortable or more comfortable dealing with drug pricing contracts, just trying to create a good program that way. But I still, probably my favorite moments of any given day are when I get to dig into the point-click care database and figure out kind of what's going on clinically with our residents.
Well, I mean, we appreciate that on our end, that intersection of business and pharmacy, I think, is the linchpin to us getting more clinical programming out there. We don't always have that economic model that goes along with that clinical intervention. The more we get from that, I think the better the pharmacy profession grows into some of those roles.
Mm-hmm.
I didn't know.
Yeah, and personally, in post-acute, I don't think we've done enough with some clinical programs, for example. And again, I'm as guilty as anyone else because I've been in this role for a long time and haven't done it. But we should have a COPD program that leverages consistent clinical care but also chooses specific products, because we can leverage that financially, and we can create a more safe, consistent nursing process as well, because our staff know those products. And residents, to use that certain inhaler a specific way, and we can create a better program. But we're all busy, and it is hard to kind of to crack those really big nuts, I guess. But that's, I think, where we can go in the future to start seeing even more improvement.
No, I agree with that. I think anticoagulants fall into that category, and I think these new GLP-1s fall in that category. I mean, these are drugs that are very successful. They do have a price tag, but there's a benefit on the back end of that price tag.
Yeah, and I don't want to apologize as a pharmacist to say we've got to make a profit, we've got to make money. For the last 100 years, drug companies and doctors have all made decisions that was hopefully clinically based, but in their best interest of their bottom line as well. Now PBMs are making decisions, seems to be probably more on their bottom line than it's clinically based. But I don't think we should have to apologize for trying to, win both sides at the same time. And, obviously patients first, but why do we not have to, or why can we not make it where it's financially advantageous for us as well?
Well, I think as from the nursing home side, we're living in such a world of scarcity financially that I think one thing that we can be really guilty of is, looking at a profit and loss statement, for example, and only seeing the expense side of that equation and not looking at the revenue side. And revenue can take a lot of different forms, Tom, kind of like you were talking about. For example, with the GLP-1s, you will hear formulary whizzes telling you to choose a certain GLP-1 that happens to come in a few $100s lower in cost. But if you look at the efficacy of that medication, the math doesn't work.
Right.
And I think, but I think so often it's easier for all of us just look at that really quick number on the expense side. And with vaccinations, for example, I think one of the reasons nursing homes struggle with pneumococcal right now is they see that high price tag for that vaccine, and they don't understand the reimbursement on the other side. And you may have to wait a little while to get that reimbursement, but it comes, and you're doing really great clinical care for your resident, and you're making a profit. And so it's really, I try to talk to people about that a lot, the importance of connecting the two sides of the equation.
Yeah, and I think to your point, vaccines in general, that's been sort of the advent this particular year of a high-dose flu, of a COVID vaccine, of a potential RSV vaccine, of the new pneumococcal vaccines. They're all new, expensive, branded vaccines, and that's not necessarily a negative. It's an opportunity, but you have to be willing to buy into that. And for some smaller nursing homes, I know that's been a challenge. Like, I'm going to write a check to buy $12,000 worth of vaccine. Hopefully I use it all. Hopefully if I don't use it all, I can return it. And those are challenges that most of them are not willing to take. And that's where a pharmacy can come in and alleviate some of that pain. But then again, the pharmacy also has to be willing to take those risks.
Or even the GLP-1s for weight loss, that's really a preventative measure, just like a vaccine would be. And so if you look at that full cycle of healthcare and healthcare cost, that kind of becomes a no-brainer.
Yeah.
I mean, I think it's true for obviously all medications, but these specifically are so effective in being able to reduce weight and help all these other medical issues.
Yeah. I'm also fast. I didn't know you were a skier. Yeah. That's awesome. We've done a lot of work with USA Boxing on a vaccine campaign to provide vaccines at USA Boxing events this past year, and it extended into a second grant with judo, curling, karate, and fencing. So, long story short, we've gotten to see the back office of U.S. sanctioned sports, how they work, how they train their athletes, how they care for their athletes. It's been amazing to see that on the back end. It sounds like you lived that with skiing. And I think ultimately what we've learned, and when we were approached, we were like, how are we connecting the pharmacists that work with older adults and boxing? But they made a compelling case that, hey, the people that watch their kids and grandkids box are older adults. Our officials are older adults. People that work for our gyms are older adults. And these are generally individuals in the Black population and the Hispanic population that have been underserved. So we think this is an opportunity to take the vaccines where they are and get them the opportunity to be vaccinated. And it's worked that way. It's been interesting to align health and, world-class level sports makes a lot of sense. These athletes are healthy. Mm-hmm. It's a good, analogy or alignment from that standpoint.
Yeah, and for the athletes, the cost of getting sick is high. Mm-hmm. With generally pretty open to preventative care in general, because they see those direct costs later on, much like our older population does. And I think that goes back to, I think, why we see that separation in the Dakotas of super high vaccination rates at our facilities paired with pretty low rates in the community, is because they're able to kind of segment that risk and see what that risk is.
Well, certainly on an event, if they, someone gets flu or, breakout of flu during an event, then the whole event's kind of ruined.
This is maybe an off-the-wall question, but do you think in rural environments, do you think there's a feeling that I need to get this vaccine because if I get sick, I'm, in the countryside and I don't have access necessarily to a quick hospital 3 minutes away, or my physician's office, or even a pharmacy? It might be close, but is there that feeling that, hey, I need to do this because I might be somewhere on my ranch or somewhere far away from help, so it may make sense for me to do these preventative things? Do you think does that move the needle in these areas versus cities?
Well, I think there might just be, it might just be easier to reach folks.
Yeah.
And, leaving, I think you're probably leaving less people behind because a single voice in our setting can really reach a lot of people. It very well could be, but I think that people do have access is an issue for sure. And Sanford Health is, we are the rural health organization in the country. So we're always thinking about telehealth access, other ways to make sure people can have access to care. But I wonder if that would be a driver, maybe.
Yeah. Interesting.
Well, Patrick, we appreciate you jumping on here. Anything that you'd like to leave us with for what's coming up in your world or in the vaccine world for 2024?
Well, sure. I could quickly bounce off what Chad was saying earlier, that I think, I don't know if it has an official name, but I think we've got to get to a place nationally where this idea of any willing provider of vaccinations, we have to be in a situation where we can pay and reimburse anyone who's licensed to administer a vaccine to someone. And right now, I think one of the reasons we've done well is because I sit at a desk and help our locations jump through hoops in terms of access. And Haley, our infection preventionist, sits at a desk and helps people jump through kind of other hoops when it comes to vaccines. And it really shouldn't have to be that way. We really should be able to just have the confidence to know that we can administer and get paid for it. So, for example, right now with Part D vaccines, our most common scenario is the pharmacy provides that Part D vaccine, but we administer. And we administer with no reimbursement in that case. And we do it because it's part of what we do. I'm not going to sit on this podcast and say it's overly burdensome. Our nurses actually like to do that work. It helps them feel close to the patients and doing their job. But it's kind of too bad that you're providing a service that you're just writing off over, and you multiply that by hundreds of locations. And that's a significant item, especially for an industry that's struggling to balance a budget. We're struggling to break even. We're a nonprofit chain, and I can tell you we don't have crazy overhead, and we're running a pretty lean operation, and we're struggling to really break even financially.
So to get something like that accomplished, if someone's listening to this podcast, what would you hope for them to do or say or get a part of?
Yeah. So if you're a pharmacist who's part of a lobbying, or maybe you're a pharmacist with a big company, I think being sure that we're not just advocating for ourselves. So when I'm advocating for the pharmacies and the pharmacists and for the nursing homes. So it shouldn't. I think we want to be careful. And I haven't heard this coming from anyone. But I think we want to make sure we're advocating for this any willing provider model.
Yeah.
Not, hey, the pharmacists need to get paid. Let's make sure we set up a system that works perfectly for the pharmacies, because that's going to be great for me in about 50% of my locations.
Right.
And then I'm going to have a bigger problem in the other 50%
Right.
if it shifts completely in that direction. But if I was out there lobbying, saying, hey, let the nursing homes take care of this and direct ship them vaccine, et cetera, it cuts off one of our potentially strongest partners, like I talked about in Sioux Falls, where we had huge rates of success because we had a pharmacy raising their hand saying, we want to do this and we want to own it for you. So I think that's the key, and that's where we need to head as we move into the future.
Yeah, I think the comment at the meeting that we went to together in November was no closed door. There should not be a closed door.
Yeah.
Whether you're a staff member or a resident, at no point should a clinician say, I'd like to give you the vaccine. You're willing to get the vaccine, but I can't. You've got to do this. You've got to either go to this other pharmacy, or we've got to get somebody else to come in here to do it. Like, that's what we have to avoid, because that's the moment of truth for getting people shots.
Mm-hmm. Yeah, I think, and I think it's way outside my expertise, or my realm of expertise. But if you go and listen to any true vaccination expert, I think it's number one on all of their lists is that you have to have a system where you don't turn people away.
Right.
At that moment that they're ready to say yes, you need to be ready to vaccinate. It's the reason I think people can get stressed out about, do we give the flu vaccine in October to time it perfectly, or do we do it in August? And nationally, we've said, let's set a wide date range and just, if they want it, get it, even if it's not maybe the perfect nuanced timing.
Right.
And so I think that's key.
Well, Patrick, thank you so much for being on. Appreciate all the work you do. Appreciate your membership at ASCP, and we'll see you at a meeting soon.
Yeah, sounds good. And I do listen to the podcast, so it's an honor to be here with you guys.
No, thank you.
Thank you.
All right, thanks everybody. We'll see you next time on Our Experience.